The production of this program is made possible thanks to the support of the following and viewers like you. Canada's vaunted healthcare system is in crisis. According to the ourCare National Survey, more than 6.5 million people, that's 1 in 5 Canadian adults, do not have access to a family doctor or a nurse practitioner that they can see for regular care. ERs are regularly shut. Diagnostic services and surgeries are backlogged, making timely access to healthcare extremely challenging. According to a Research Co. poll, pessimistic views on healthcare have taken hold in Canada. The proportion of Canadians who think the system should be completely rebuilt has jumped to 23% in 2024. Krystale Wittevrongel says that's a startling number. It demonstrates that Canadians believe it's time to drastically change the system. One of the many impediments to the delivery of healthcare, says Wittevrongel, is our funding model. Hospitals receive a global budget at the beginning of the fiscal year. That money is fixed based on an expected number of procedures based on historical volumes. This funding model has been replaced in most OECD countries with activity-based funding. I invited Krystale Wittevrongel, the Director of Research at the Montreal Economic Institute, to join me for a conversation that matters about healing our ailing healthcare system. Krystale, welcome.
Thank you so much for having me.
It's bad, isn't it?
Oh, it's bad. Yeah.
With the unvarnished truth, how bad is it?
Well, it depends on what we're talking about when we're talking about bad. But when we look at hospital funding, specifically the global budgets and activity-based funding, it's bad because we've made it bad in the sense of we've baked in the system. We're now dealing with the consequences of it. And we see it all over the country. Wait times in ERs are ballooning. We've got people on wait lists for elective surgeries that go on long before they're, chronically ill. So it's bad.
Why is global funding a challenge in helping us to streamline and speed up the delivery of healthcare, especially within hospital settings?
So with global budget hospital financing, they allot a set amount of money for the current year's activities based on historical volumes. So, you did 20 knee surgeries last year, we're going to give you money for 20 knee surgeries this year.
Even if you need 23, too bad.
Exactly. Or 15. You've got this amount of money, you are expected to make the budget work. That's how you're going to ration the resources. So stretching that budget leaves people without the care that they need in a timely manner or at all. And so being able to actually connect the funding on a one-to-one level in real time actually permits the incentives to align with the actual care.
So this is the money you're going to get to do this. So therefore, the thinking is within the administration, that's what we're going to do, even though the needs may be different.
Exactly. And so, in a business sense, this is what you're funded for, this is what you will do. There's no real incentive to increase your efficiency and make it faster because you actually end up losing money if you're doing more surgeries than what you're being paid for, essentially. So it really just skews the incentives, and there's no real way to keep up with the growing demands of healthcare when it's based on previous year's activities. It's not real time what's happening.
So I've heard it been said that when a patient comes in, let's say to have a hip surgery, the hospital looks at that and goes, okay, you're an expenditure. You're actually something that's coming out of my budget. Okay, I'm gonna limit the number of surgeries because I can't have too much of that money come out of the budget. What's the reverse to that, though? How do we offer an alternative to hospitals with a funding model that says, oh, you're a hip surgery. You actually come with funding to help balance out our budget. How do we change that model? And where have we seen it actually implemented?
So changing that model, it's not a simple thing because it's a funding model, but it is as simple as you just laid it out. Moving from global budgets to activity-based funding changes the way that a patient is viewed. It's now seen as a source of revenue, part of the hospital's operating strategy, rather than as a cost that needs to be contained. So if we look to other OECD countries around the world, most of them are using activity-based funding. So Australia, for example, has 87% in the last year of their hospital funding is done on an activity-based formula.
And the funder still being the government?
Yeah.
Really? 87%?
87%. So there are circumstances where it isn't necessarily the best way of moving forward. So, small rural centers where there's no competition between hospitals or inability to properly calibrate based on, some unique cases or whatnot. So there are still block grants or global budgets in some scenarios in other countries, but it is not the norm.
And so that makes accommodations then for those regions or local rural areas that, you do need global funding. But the rest of the system can benefit from an activity-based funding.
Absolutely. So it's almost stimulating competition between hospitals. So if you think in a large urban center, one hospital is known for being very quick and efficient and very few readmissions. They're going to have more patients likely to proceed to them for needed surgeries and so on. Another hospital that doesn't do as good of a job is going to lose patients and then lose funding. So it really connects the dots between the funding, the patients, and moving forward to bring about systemic change within the competitive mindset. But yes, there are concessions that are made for smaller centers or certain like research hospitals, for example, might have different considerations. They're not doing as much direct patient care or whatnot. And that's the beauty of considering it here. Australia has 20 plus years of in-depth, tweaking and on the go. We're not going to reinvent the wheel. We don't need to. We can learn from countries that have these experiences that are very applicable to our own.
The production of this program is made possible thanks to the support of the following and viewers like you. So I was, made aware of something that, okay, you go in and have a procedure here and something goes wrong. Well, and you have to come back and there needs to be another surgery. Well, this is a huge hit to the hospital's budget. And they have to, of course, address the need that was created by them. But in these countries, or some of them, that there is, in essence, kind of a quality control measure that, okay, you didn't deliver what that patient requested or needed. We funded it, but you have a responsibility to make good. You, the hospital, have a responsibility to make good. What has been interesting is to see the relatively low rate at which there is a readmission because something went wrong, because there's a consequence, like a severe consequence to getting it wrong. Here, yeah, you take it out of part of the budget, but the hospital's still functioning. There, no, it's costing them. So yes, you get paid for the patient coming in, but you don't do it right, you're now paying. Do I have that right? And what are the benefits of creating a system like that? Like, how does that then start to improve patient care or patient health outcomes?
So in Australia, they do have it baked in where if there is a readmission or a hospital-acquired infection or other complication, it's factored into the costing and the way that they're paid with these services. So in effect, you are correct by saying, they are then kind of out of pocket for that. They're not being paid, multiple services when it's in fact a quality control issue. So that's one of the things that I think is really beautiful about this is these other places have really put this stuff into play for so many years that we can say, okay, that is a good indicator of low quality, or alternatively, something is a good indicator of high quality, and what does that mean in terms of funding? So moving from that.
Australia is not the only country, and there is a knee-jerk reaction here in Canada to say, oh, okay, so you want us to go to the American model. What I found interesting is if you take a look at surveys of Canadians, as I pointed out off the top, there is an appetite for change. But the appetite doesn't seem to be to mimic the American model. It seems to be to look for other overseas models. What about Sweden, for instance? I understand that they have quite a remarkable model as well.
Yes, Sweden, Denmark, Germany, England, they all incorporate activity-based funding and all have similarly high adoption rates as well. Australia, yeah, 87% is definitely among the highest, and Denmark's around 80%, but there are other circumstances. When we look closer to home, we've had some provincial experimentation. Quebec right now is actually leading in this area. In 2027, 2028, the goal is 100% of physical care in Quebec hospitals to be funded by ABF or activity-based funding. Currently, it's about 25%. It's been rolling in stages and phases over the past few years with really remarkable results. We've seen in magnetic resonance imaging,
MRIs,
so MRIs, an increase of 22% while driving down the cost at the same time by, I believe it was 4 or 5%. So we're getting more services at a lower cost. And we're seeing that here in Canada as well.
So what happened politically in Quebec that allowed for the introduction of this model? Because up till now, I think that if you were asked to ask a lot of Canadians, I mean, we do have pride in our healthcare system, and for good reason. I mean, there's lots of good things about it. But if you ask somebody to say, okay, well, we're going to start to change the way in which we deliver especially the financial resources to make this work, there has been resistance, especially at the political level, not necessarily so much the public, but much more so at the political level. What shifted in Quebec?
Well, Quebec is interesting because there's more of a desire, I guess, to experiment. They do have a little bit more flexibility when it comes to healthcare. They do have things a little differently, and there's more of a desire and a push for change there. And they see it, and it's really been forward moving. So there was something, I believe it was last summer, they were pushing for some mini hospitals, which were going to be introduced for a number of different things. It's since been rolled back politically, but one of the things that we recommended was, you know what, you need to do this with activity-based funding for this to be successful in the way that you're hoping. And so these recommendations that we've been making, I'm not attributing the success to us by any stretch, but you know, we've been pushing this for years, and they're finally starting to catch on that other places are doing this well with these sorts of formulations. And whether it's, you know, the Quebec desire for experimentation with health, or just, you know, more fed up with the federal overreach, which is also something we see in Alberta, there's just more desire for change, I think.
The production of this program is made possible thanks to the support of the following and viewers like you. Do you believe that the Chihuly case in Quebec may have also played a role because the Supreme Court of Canada said, you're right, you do not have timely access to health care and you have a right to that? I mean, this is one of the challenges. We're supposed to have a right to timely, effective health care, and in the rest of Canada, in British Columbia, of course, there was a case that went to the Supreme Court, and they said, no, it doesn't apply here. But the Chihuly case, I think, must have had some political influence saying you cannot be denying people the access to care, because if you do, then they have the right to go and seek out other healthcare opportunities.
Yeah, I do think that that has something to do with it. If even just to speak to the desire of Quebecers for alternative options. But it's been almost 20 years since the Chihuly case came down, and we aren't really seeing what we would have thought or championed. You know, a more narrow interpretation of the decision has really put a bit of a shackle on what can be done. However, it is more that can be done in Quebec than in other provinces. You're right.
So what are the proposals that are on the table in Alberta right now?
With activity-based funding?
Yes.
They haven't, as far as I know, there hasn't been any real broad sweeping proposal for this in Alberta. We did have some long-term care funding done under ABF in the past. In British Columbia, though, it's the interesting one is the BC Conservatives have actually made it part of their platform.
Yes, they have.
They're patient-focused or patient. It's not called activity-based funding, but that's effectively what it is. So they've said, you know what, we're going to move to this. And there is some history of it here in BC as well. From 2010 to 2013, there was a pilot project. It didn't progress past that, but it's still there. The embers are still there. We're just seeing it kind of come back to be.
So the pushback, especially seeing as we're in an election season right now, is to say, well, this is going to add $4 to $5 billion to healthcare costs. Is there any evidence to support that claim?
So interestingly, one gentleman that I spoke with from Sweden said, yeah, you will see an increase, an initial increase, because it's based on activity, but in the long run, it will kind of level itself out. And that's not been the experience in Sweden. I don't believe it has been the experience in Australia as well. So I think...
What hasn't been the experience? That it has leveled out or it hasn't leveled out?
Oh, sorry, that it stayed high,
okay.
That it didn't level out, and that over time, the long run expenditures normalized.
They normalized, okay. But you were getting a better, I guess, return on investment in your healthcare dollar. Exactly.
And when it comes to activity-based funding, it's interesting because there's a difference between price and cost. So the price of a service might be $5, but the actual cost might be $4 or whatever you want it to be, based on the political context, the policy context of that particular environment. So whether you're trying to drive efficiency and make it so that there's more procedures or lower costs, you can do that with activity-based funding by just kind of tweaking at the margins and playing with the policy context that actually is in front of you.
So one of the other components in our healthcare system here is that, no, you have to come through the system and that's it. The delivery of services through private healthcare providers, even though they may be specialized in certain areas, there is or has been a response that says, no, we don't want to welcome that. But what are the economic benefits of starting to be able to say to patients, yes, you can go get your MRI there. Yes, you can get your knee done here. You can get your hip done there. How does that help budgets at hospitals? And then how does it also improve the delivery of healthcare for people?
I think part of the conversation that as Canadians we often get conflated is private delivery versus private payment. Healthcare is already delivered on a large scale privately. Your family doctor is a private provider. My family doctor is a private provider. There's now chartered surgical facilities, that's what we call them in Alberta anyways, that are privately run but publicly paid. So it's not a matter of needing to pay out of pocket for these services if they're delivered privately. And I think that's where people get heated or people get upset to talk about is private healthcare. It sounds horrible, but we already have so much of it in the current system. When it comes to hospitals, that's entirely different. It's, a publicly paid, publicly run facility, ultimately.
The production of this program is made possible thanks to the support of the following and viewers like you. But if we look at these private facilities that are delivering a public health care benefit that's paid for by the province or the government, is that not activity-based funding in playing itself out right there? Because the private clinic isn't getting global funding, it's getting funding based on the patient who comes through the door. And right there we have an example of it working and it's creating benefits to the system overall.
That's a really great question. I'm not sure how those private surgical facilities are actually funded. So that's a great note and something I definitely will look into now after this conversation, because I'm not sure how that works or how they are funded. I know that they're funded for a certain number of procedures. So that, to me, that sounds like activity-based funding, but I'm not entirely sure.
Well, in talking to Brian Day at the Cambie Clinic, he has other sources of revenue, but they come from the Insurance Corporation of British Columbia, because they want to have a quicker healthcare or recovery time, because it reduces payments for them. It comes from workers' compensation. It comes from the government to pay for healthcare delivery to politicians, judges, and others, and people who are in prison. And that funding comes to them as they're receiving those patients. And so, in a way, it is a mini model of exactly what we're talking about here, and it helps to alleviate pressure on the system and be cost effective.
Yeah, I think as I'm sitting here thinking about it, it's definitely very much like an activity-based funding model. But when we build up they're called DRGs, or diagnostic related groups, for activity-based funding, they often include capital expenditures and admin and sorts of things like that, which I don't think the chartered surgical facilities have that built in. So it's not entirely a true activity-based funding model, but I do get your point. It's definitely, a step in between.
The whole point here, though, is to try and deliver healthcare in a way that meets the needs of Canadians. I heard a really interesting quote this morning at the summit that you were making a presentation at, that said Canadians want access to healthcare the same way they have access to anything else, on their time, on their terms, and when they need it. And this is what we really need to be driving towards. The ability to deliver healthcare in a way that meets the needs of individual patients. And I know that we're kind of on all right, let's do this. But in an odd sort of way, I also want to appreciate that there's so many good things about the way that we deliver healthcare in Canada. I don't think that anybody's advocating, oh, well, let's just throw it all out and start again.
Yeah, exactly. But at the same time, it's also, let's not just keep dumping millions and billions of dollars into something that is giving us subpar results, and really just, people are paying, just not with money, they're paying with their time, they're paying with their quality of life. If you spend 2 to 3 years on a wait list for a hip and you now are living with chronic pain, I don't think that you're necessarily excited about the way that health is delivered. There are good things about it. In an emergency, you can likely get care before you perish, but is that all we're looking forward to? Is the very extreme circumstances where that is accessible to us versus the 6.5 million Canadians who don't have a family doctor and can't access a family doctor? There's a lot that needs to be looked at, while also still saying, yes, okay, the safety net is there and it can be useful at times. I
know, it's an odd system. You go, okay, I've got this problem. Yeah, but it's not bad enough, so come back and see us in a year and a half when it really is. So I see this deterioration in the quality of my life and the discomfort that I have, only to be told, well, we really should have got to this 6 months ago.
Yeah, exactly. Or even waiting for a referral to a specialist from your family doctor, that can often be lost. And in what case are you, reimbursed for that with your time or your money or anything? It doesn't happen.
Well, I hope that there's a growing chorus of voices that say we need this change, and the political, people that represent us are starting to hear them. Thanks for coming in and having this conversation with me.
Thank you for having me.